Hello and welcome to Askimo TV. I'm talking today to Dr. Vel Sakthivel. Dr. Sakthivel is the lead doctor for Department of Children's Orthopaedics at University Hospital Southampton in the UK. He specializes in children's orthopaedics and sports injuries around the knee. Hi, Dr. Sakthivel. How are you?
Hi, Joanne. Hi. I'm fine. Thank you. Thank you.
Great. Wonderful to be talking to you today. Dr. Sakthivel, let's talk today about pediatric orthopedics and in particular hip dysplasia. So what is hip dysplasia?
Well, hip dysplasia is a term. It's actually a term coined for a spectrum of conditions. It essentially means that the ball and socket joint of the hip are not well formed. It may be that the socket is more shallow than it really should be, or the ball is not sitting in the socket as well as it should be. And for the socket and the ball to develop, the ball has to be well seated into the socket. So it could mean a spectrum of conditions, but essentially it's a shallow socket.
And what causes hip dysplasia and who would be at risk of getting this?
Well, the common reasons for hip dysplasia is unknown, really. What we would like to speculate is that it is what we call a packaging disorder. So the baby is packaged inside mummy's tummy, and it can be squashed inside mummy's tummy, for want of a better phrase, and that positions the hip in a place where it's not friendly to the hip, to the body. And that can push out the ball out of the socket and things like that. Now, there are conditions which can predispose to forming this hip dysplasia, and those are, not very common as what we call idiopathic causes, which are known causes for it. You can have hip dysplasia in conditions with cerebral palsy, for example, but those are few and far between. And the most common condition is that these are part of the packaging disorder. So if you take that into consideration, any child who is the first child to mum, because her womb is not spacious, it's the first time having a baby inside, they have a risk of being squashed. A twin pregnancy, there's no room for two people, the babies are squashed against each other. Things like not enough fluid inside the womb around mummy's tummy, what we call oligohydramnios, and that can cause a bit of squashing of the baby. So all these things are predisposing factors. The main factors which your viewers should be aware of are breech presentation of the baby. So for people who do not know that, it's sort of the head coming first, the baby's bum comes first. So that's the breech presentation. And the other one is a positive family history. So if mum or mum's close family or dad, the close family have got or had got dysplasia in the past, when they were a baby, then they have a big risk that could happen in their babies. So if these two factors, the breech presentation and positive family history, are present, then what we do in Southampton is we have a routine screening for these patients, whether they have symptoms or not. We just screen them for hip dysplasia.
What would some of the symptoms be of hip dysplasia?
It's a very interesting question because sometimes you can't get any symptoms, okay? And hence, there are some babies who get missed for the first few years because they don't have any symptoms. People think that with a dislocated hip, children can't walk. That's not true. Children can walk very, very, comfortably. There is no pain into this condition. It's a painless condition. So these two factors, make it confusing for the mums or the dads to pick these things up. So it usually is picked up with examination of the baby by the pediatrician or the neonatologist who delivers the baby, or not delivers the baby, who looks after the baby when they're delivered. And what we look for when we examine is the movement of the hip is reduced. and we compare that with the other hip, and if both hips are dislocated, then it's a little bit more tricky, but the essential finding for us to look out for is a reduction in movement of the hip. And sometimes you've got to follow the mum's instinct, and mum's instincts are usually right, okay? They come back and say, well, my baby doesn't walk well, it kind of has to drag the leg along a little bit. And so these sort of things are what we class as loose indications or loose clinical symptoms. But essentially, if those are any concerns or anxieties, we get them in, we examine them, maybe scan them, and then very rarely in the older child, we may have to X-ray the hips. Okay, so the clinical signs are very difficult to pick up for the family. That's the main thing. Okay.
If you do find that there's hip dysplasia, what are some of the treatment options that are available?
Well, earlier you identify it, better the success rate. Okay, and say for example, we identify them in 2 weeks or 6 weeks after delivery, and that's how quick we need to be. I'm not trying to scare your viewers, but essentially, because we have this screening program, we kind of tend to pick these patients up very early on. And when we do pick them up at 2 weeks and 6 weeks, what happens is we put them in something called a Paediatric harness. And now that is it's a loose splint for the baby. It goes, from from chest to legs. And essentially what it does is it holds the hip in a certain position where we would like it to be. But the baby can kick the legs, move the legs to a degree, not as much, but to a degree. So it is, the Paediatric harness is what we call a mobile splint. Okay, and that holds the hips in a very good position. And that's got a success rate of very close to 90+%, okay, 90-95%. So the key to treatment is identifying them early, and we do not need any more treatment if we have good success with the Paediatric harness. Now, if you do for some reason miss the early diagnosis or the Paediatric harness fails, then we have subsequent treatment which will involve an anesthetic, where we then have to put a dye into the hip. It is just to give an injection into the hip to identify a bit more clearly where the ball and the socket joint is in the body. Because you've got to understand that as a child, as a baby, the bones are not well formed. So X-rays would not be a very good investigation for these babies. It does depend on age. And then that's called an arthrogram, which is a dye test. So we squirt the dye inside the hip, move the hip, and that gives us a better clue as to where the ball and the socket joint is in place. And after that, we can then initiate different kinds of treatment, like a closed reduction, which is like a manipulation of the hip into the socket, or an open reduction, where we actually have to open the whole hip up and clear it up and put the ball in the socket. So there are various things we can do.
Dr. Sakthivel, just to end off, what is the prognosis for children suffering from hip dysplasia, and can it have any effect on their hips later on in life?
The prognosis, it does depend on a couple of things. One is whether it is an idiopathic dysplasia, which means no known cause for it, which is the most common reason, okay? It's like what I told before as a packaging disorder. If that is the only reason for the dysplasia. And the timing of diagnosis, okay? Say, for example, the best case scenario is you have a baby who we identified in 2 weeks, and we put the harness on, and that, we can treat it straight away. There's no other known cause for dysplasia. Their hips will be perfect, okay? That is the outcome. I can't guarantee that. I don't want your viewers to be expecting that, but it is a, more often than not, nearly all the time, these hips would behave very nicely, and there are no long-term implications. However, the worst case scenario, if there is a reason for the hip dysplasia, like a muscular problem, a neurological problem, or we identify it later on in life, then we have to keep following their hips for a longer time, and more surgery is required, and things like that. but their prognosis may not be that brilliant. But we can get them a painless, well-functioning hip, but there may be some restrictions on their activities in daily living.
Thank you, Dr. Sakthivel. Thank you so much for talking to me today.
Thank you. Thanks, Joanne.